Good evening, everybody, and welcome to the Resident Smart Learning Program. Today, we have an important topic on metabolic evaluation of urolithiasis and the medical management of urolithiasis, which is being dealt by Dr. Bobby Viswaroop from Vedanagam Hospital in Coimbatore. Bobby is a senior consultant urologist at Coimbatore, and he graduated from CMC Vellore, a good teacher. He will cover most of the aspects which are required in this topic. With this few introduction lines, I would now call upon Dr. Rajiv Sood, Chairman ISU, to give his opening remarks. Over to you, Dr. Rajiv Sood.
Thank you, Dr. Keshav. This is a great times going on, even with COVID around, Omicron around. We are continuing uninterrupted with our educational programs, and this is one topic which is Dr. Viswaroop is going to take up, which is very important for the students, for the consultants, and also for the practitioners, because stone disease is very important for our educational point of view, also clinical practice. Also, we are living here, at least in Delhi or in northern India, in the stone belt. There are certain stone belts in the world, and we are part of that. And major stone belt goes through India. And also, when we talk about the management of the stone, it is the important observation that recurrences are the consequences. And if you want to prevent the recurrences, most important is to understand the metabolic workup, and also the metabolic aspects of the stone disease. So how the stone is to be managed is not important. How is that is also important, that how the stone is going to be subsequently dealt with, and prevention is to be is to be stopped. So today all the aspects are going to be discussed in detail, and we are very fortunate that very eminent professor is with us from Coimbatore, who will be deliberating. I request all the residents and also the young consultants to be interactive and to participate. And with this participatory approach only, this uniform, the mission of uniform education and curriculum is going to be fulfilled. I'll now hand over back to our secretary, so that Dr. Arun Chawla can properly introduce the
Thank you, Professor Sood. Over to Dr. Arun Chawla for the introduction of the speaker and then moderating the session. Over to you, Arun.
Thank you, Dr. Keshav. I have a very pleasant duty to introduce today's faculty, Dr. Bobby Viswaroop, to you all. As Dr. Keshav mentioned, Dr. Bobby Viswaroop has done his residency in urology from Vellore. He passed his MCH in 2004, and after his MCH, he served as a faculty in the CMC Vellore from 2004 to 2006. After gaining proficiency in all the spheres of urology, he moved to practice as consultant at Vedanagam Hospital at Coimbatore, but has remained attached to academics in spite of his busy practice. He has got more than a dozen publications to his credit, and 3 chapters in different urology books under his name. He has recognized PG teacher in urology under National Board for DNB for many years. Many awards to his credit, notably the USI MIUC Traveling Fellowship under his name. He's a very gifted surgeon with excellent surgical skills, and his main area of interest is reconstructive urology and stone disease. And he has remained always active in the academic programs at zonal and national level. Dear agents, as you all know, that endourology management of stones is very interesting to read when you are reading your Campbell, but what usually we skip and remains less touched is the medical management. And today he will make you learn about the principles of medical management in urolithiasis, including metabolic evaluation and touching recent advances in the medical management. And this remains a very important part of our clinical practice before the stone evaluation, and many times after the endourological management of the stones. I urge all of you to stay active during the presentations, and you are all invited to put your doubt and question in the chat box. With this, happy learning to all of you, and I invite Dr. Bobby Viswaroop to take over and start his presentation. Over to you, sir.
Good evening, Dr. Arun, all the USI senior members, and dear friends. Thanks, Arun, for the kind introduction. My sincere thanks to USI Education Cell, especially Dr. Keshamurthy, for providing me this opportunity to be part of the student learning program. Indirectly, it provided me a chance to update myself on this day-to-day problem. This is the outline of my talk. Kidney stone disease is highly prevalent. It affects 1 in 8 at some point of their lifetime. Prevalence is increasing because of global warming and due to change in diet patterns and increase in diabetes. Aortic colic is one of the worst type of pain one can suffer. The need for emergency medical care, life interruptions, missed work, surgical treatment all adds to morbidity and affects quality of life. Like erectile dysfunction is a marker of coronary artery disease, stone disease is a harbinger of systemic disease. It not only is associated with hypertension, coronary vascular disease, it affects bone health and chronic kidney disease. Also adds to insulin resistance. Moreover, it carries significant economic burden. In the US, the cost of treating a stone disease in 2000 was 2.8 billion, and it is expected to exceed 4 billion by 2030. A paper published in BJUI on evaluation of economic burden shows that the cost of treating stone disease in UK in 2010 was between 190 to 320 million pounds. Interestingly, the cost of treating a stone disease is comparable to a combined cost of bladder and prostate cancer. And that makes the evaluation and treatment of stone disease very important. Stone formation is a metabolic process, and by doing metabolic evaluation, we should be able to answer most of the questions. But the problem is the etiology being multifactorial, and there are a lot of areas which we cannot get an information or able to analyze, and that makes the metabolic evaluation a challenging process. But still, people argue that doing a metabolic evaluation is important as it provides precise diagnosis of stone composition, identifies the urinary risk factors, and forms a rational basis for treating stones instead of being a quackery-like treatment. The arguments against are that the metabolic evaluation will not provide all the information which is required. It adds to the cost which is already overburdening. The reliability and feasibility of the test is challenging. And moreover, lack of motivation, both from the patient and physician, is another factor. Who should have metabolic evaluation? This is known to all of you. Children with stone disease should have complete metabolic evaluation. So are the patients with recurrent stone disease, stone formers, patients with strong family history, patients with solitary kidney, and patients who have renal insufficiency. And certain stone compositions like cystine and uric acid stone should have metabolic evaluation. Metabolic evaluation is also extended to all the first-time stone formers, but this needs to be taken at the cost, and it should be offered to patients who are willing to undergo these tests. So as a clinical principle, even the first-time stone formers who would like to know the risk factors should have metabolic evaluation. Can we stratify this? Yes. Rule et al. Looked at 2,239 first-time stone formers, and they observed in 707 patients who had recurrence of stones over 15 years. The recurrence first 2 years was 11%, and the recurrence fell to 40% but 15 years. So the standard rule of recurrence, which is 5 to 7% per year and 50% at 10 years, is questionable. And also, this gives us information that we need to have a close monitoring of these patients in the early years, and we can lessen the evaluation or imaging methods in later years if there is no evidence of newer stones. The risk factors which these authors considered were younger age, white race, male, family history, prior asymptomatic or non-obstructing stone on imaging, symptomatic renal pelvic or lower calcium stone, glossomaturia, and uric acid. From that, they had put into this nomogram and calculated the risk. In their study, the lowest risk quintile had 12% risk at 10 years as compared to 56% in patients who had more of these risk factors. This study is not validated. But we are going to get more of artificial intelligence into networks being used into assessing, incorporating these risk factors, and probably we will be able to subselect patients who require complete metabolic evaluation and then medical management. Because of various guidelines which are existing in urology, it is not only from urological side, from physicians, from nephrologists, from endocrine. There are various terminologies which are used for to use types of metabolic evaluation. To us, you should remember simple that it is simple metabolic evaluation or a complete metabolic evaluation. The simple meaning, it encompasses history, examination, urine microscopy, blood chemistry, imaging, and stone analysis. When we add component of 24-hour urine analysis into that, it becomes a complete metabolic evaluation. There is ongoing work in this endoscopy, which we will touch upon in subsequent slides. In the history, we should know what's the occupation of the patient, the lifestyle, and look at the dietary excesses. It is preferable to use a regular dietitian to get a good diet chart, 24-hour diet chart, to look at fluid intake and number of stone episodes, and also the last stone episode. That is very important because the time from the previous episode, if it is more, the chances of recurrence is less. And there is a terminology called occasional stone former. That is, if from the first episode to the second episode, if it is more than 5 years, it is called occasional stone former. So more the number of stone-free years, less is the risk of stone recurrence. So that is also need to be documented. Urine analysis basically looks at the pH, which gives us an indicator of whether the stone is of infection stone or uric acid stone at the extremes of pH. Sediments per crystals throw a light and it is diagnostic when it comes to cystine stones. As shown here is the hexagonal crystal, which are pathognomonic of cystine stones. Culture is important to know the infection process and also during management. It is common practice to use multi-channel blood screen for all patients who presents with stone as part of a lab workup. But we actually don't look at most of these results except for calcium. So what we should do is we should do only if there has a high index of suspicion, and in case if you are thinking in terms of distal renal tubular acidosis or hyperparathyroidism, then the entire blood workup needs to be done. This is in the same lines as NICE guidelines, and even the European Association of Neurology endorses doing only serum calcium as the blood test, and to do the other test only if we have a clinical suspicion. Imaging is the key in the stone disease. It helps in diagnosing, knowing the functional and anatomical aspects of the kidney, choosing and executing treatment, also in follow-up. From imaging, we can know whether the stone is metabolically active or inactive. What is metabolically active? If there is a new stone formation, or if there is existing stone, if it shows increasing in size, suggests that the patient is having metabolically active stone disease, and indicates that we need to do metabolic evaluation. What is the definition of new stone? It is defined as passage or removal of a stone that cannot be accounted for by loss previously seen. So these definitions are good for a clinician to use in follow-up of these patients. Commonly used imaging was X-ray, KUB, and ultrasonography, but now it is shifted towards non-contrast CT. The main problem being the radiation dose, which is addressed by low dose and ultra low dose CT scans. We talk about the advantages of other imaging techniques in subsequent slides. Stone analysis is an integral part of metabolic evaluation, and many believe that it provides guidance for therapeutic treatment and obviate a formal metabolic evaluation. There are many techniques. There's a wet and dry method, chemical versus physical, qualitative versus semi-quantitative, microscopic versus macroscopic. Among these tests, the one which is recommended is either X-ray diffraction or Fourier transfer infrared spectroscopy. This is the kinds of reports we come across. One on the left side shows a wet stone analysis, which tells us about what is the crystal components which are present. Whereas if you see on the right side from the spectroscopy, we get the different stone compositions and the percentages of each component. And it is also useful when it comes to picking up drug-induced stone and rare types of stones. But doing an infrared spectroscopy, the stone is crushed into powder. But there is an interesting title from these authors which talks about kidney stone analysis. Give me your stone, I will tell you who you are. They actually brought in a concept of looking at the stone in entirety, like a full biopsy specimen, rather than doing a punch biopsy or a biochemical biopsy. And they sorry, I'm getting some messages.
No problem.
Also, this is what the authors proposed as a morpho-constitutional analysis. Here, if you see they looked at the entire stone, we have to start looking from the surface and the cut section like a pathology specimen. And if we look at this cut section, there are multiple layers and each component telling different stories. So the authors looked at each component and then submitted these things into chemical analysis. And from that, they derived what is the possible etiological factors which contributed for the formation of each component. The problem here is that it is more of a past history. We may not know what's happening now or what will happen in the future. But this provides a good outline for understanding the stone components and also in classifying. These authors classified stones into 7 subtypes. The recent one has a 7th component as miscellaneous and 21 subcategories. And we know here that even though the first component is calcium oxalate monohydrate, but it is subcategorized based upon different etiological causes. So we know what is the stone composition, and also we know what is the possible causative factor. If it is a mixed stone, that is the most common, in their own series of more than 10,000, only 7% of the cases were pure stones. So if there is a mixed stone, they also had a classification and possible etiological factors for those causes, those conditions. The main advantage of doing stone analysis is when it comes to detecting a true stone from an artifact or a factitious stone. And also when we have to diagnose rare stones like melamine stones, xanthine stones. It also helps us in knowing whether it is a calcium or non-calcium, by which we can streamline our metabolic workup. As authors have shown, we can know what is the possible etiology, and definitely it helps in the epidemiological studies. To summarize, stone in its entirety to be studied, biochemical biopsy is insufficient, combination of qualitative and quantitative assays are important, and stone analysis is complementary. Now there is a shift from in vitro stone analysis to in vivo. One is the use of dual energy CT, which uses 2 energy at the same acquisition time. And this uses the principle of tissues having 2 attenuations at different exposure to different energies. And that is used in understanding the chemical composition of the stone. And they are able to do the same classification based upon the CT. And this is being correlated well with crystallographic studies. And being imaging, we can have advanced information about the fragility of the stone, and it will help in choosing the treatment option. The latest generation, 3rd generation dual energy CT has reduced the radiation dose, and it is also reduced the image noise, so it provides better image qualities. Micro CT is something which is being talked about. It has 1,000 times more resolution than the conventional CT scans. It provides non-destructive imaging of the stone as compared to the infrared spectroscopy, and it has a 3D resolution of the crystalline structure. It can differentiate stones formed on Randolph's plaque from those formed on the ductal plugs, and improves stone classification and aids in research. The problem with micro CT is the cost and the time in processing this information. There is a large information which is generated, and it requires special computers. This is an example of a micro CT image of a stone, and how different components of the stone are compared with the FTIR spectroscopy, and how micro CT can give information on stone which is formed on a Randolph's plaque, or on an intrarectal plug. Endoscopy is coming in a big way, and that is the one which is shifting the stone analysis from in vitro to in vivo. So as urologists, we are seeing stones every day in our management, and we should incorporate this into our day-to-day practice to further enhance the metabolic evaluation and treatment. So looking at the morpho-constitution analysis, what Dowden and et al. Proposed, we can do that during our endoscopic stone management. And during the laser fragmentation, we know whether the stone has a single component or it has got multiple components. And it also gives us an opportunity to look at the papilla, and endoscopic papillary studies are coming in a big way. And the advantages of endoscopic papillary studies is when is especially useful in calcium stone formers and helps in distinguishing idiopathic from hereditary hypercalciuria. And it is also helps in knowing the disease activity. So there is a shift from in vitro to in vivo stone analysis, and probably that is the way in future. 24-hour analysis is the one which completes the metabolic workup, and this is very important as it helps us in classifying as well as treatment. It is advised to do when patient is stone free, but you can do this even when patient has a stone, asymptomatic stone. 24-hour analysis can be done. But if somebody had a surgical intervention, it is advised to wait for up to 3 weeks. And it is better to do it in ambulatory setting and patient's self-determined diet. It is common practice that if we do any test, if we have more samples, we get better results. So true with 24-hour urine analysis also. But because of the cost and compliance, people have looked at one test, one sample alone. And this is debate which is always exists. But it is recommended to do 2 collections at preferably in 2 non-consecutive days at an interval of 3 to 10 days. To avoid this 24-hour collection, the modifications have come up. People have looked at urine samples collected over 12 hours from 7 p.m. to 7 a.m. to improve the compliance, and it is shown to be comparable to 24-hour urine analysis. Urine spot tests are good, but they have their own innate limitations. So if we collect 24-hour urine samples, better to use a non-acidic agent as a preservative. pH should be monitored by pH meter, and it is preferable to check for volume, pH, calcium, uric acid, sodium, oxalate, citrate, urea, and creatinine. It is also suggested to incorporate other electrolytes for the study like potassium, magnesium, phosphate, sulfate. The 24-hour analysis is done by either enzymatic assays or chromatography, either high-performance liquid chromatography or ion chromatography. Cystine screening should be performed at least once in each patient. Colorimetric nitroprusside technique for cystinuria, it becomes positive only when the cystine concentration is more than 75 milligrams. And chromatography is also useful, but it cannot differentiate if cystine from someone who is on a thiol drug, if they are on medications, which especially the thiols. At that time, the test becomes negative. 24-hour immunochemistry is also helpful in knowing the diet status. If sodium will tell, urine sodium will tell us about the salt intake of the patient. Urea tells us about the total protein intake. Urinary sulfate about the animal protein intake, and uric acid is a reliable marker for non-dairy proteins. So 24-hour urine chemistry not only tells us about the metabolic factors, but also about the dietary components, and also tells us about whether the collection, like for example, looking at 24-hour urine creatine, tells us whether the sample was of an adequate nature. It is also important in during follow-up. It tells us about the compliance and the response to the dietary and pharmacological treatment, and helps us in further modifications. And also we can use this as a motivational tool. If we have initiated or a pharmacological treatment, it is advised to repeat this test 8 to 12 weeks after starting pharmacological treatment. This enables adjusting the drug dose if urinary risk factors have not normalized. Once urinary parameters have normalized, it is sufficient to perform 24-hour urine evaluation every 12 months. The problems with 24-hour urine analysis is that it is done only in 7% of the stool formers across the globe. Even those who have, only of 16% of them will have a repeat 24-hour testing. The problem is with collection, and many laboratories do not do the complete panel. Quality control is a big issue, especially when it comes to citrate. Even in tertiary care hospitals, academic institutions, the quality control about oxalate and citrate is a big issue. Compliance, usually they have to wait for a weekend, and diet and normal work is compromised, and analysis may not be true, especially with current internet searching. People can alter their diet and it can give a false results. To summarize, 24-hour urine analysis is very important to understand the lithogenic process. It helps in the underlying disease, classification, and propose individualized pharmacological and diet interventions. So when we do this metabolic evaluation, we know what is a stone, whether it's calcium or non-calcium containing stone. And based upon the 24-hour urine analysis, we know what is in excess and what is in deficient. So this information, we can use it in our treatment. Hippocrates said, let food be thy medicine and medicine be thy food. It's very true when we treat stone disease. It involves both diet as well as drug therapy. The diet therapy is a general one, addresses multiple factors, does not need costly tests, and it is essential irrespective of type of stones. And it is the first step we use in treating these patients. Whereas drug therapy is specific and it is based upon metabolic evaluation. The problem is it targets a single factor, adds to the cost, compliance is an issue, and the side effect of drugs are another issue, challenging factors. The diet consists of basically 3 F's: fluid, fruits, and fiber, and salt restriction and limiting animal protein. The drugs are what is enlisted here, and if you know that this is a sorry state with over the fluid intake should be between 2.5 to 3 liters per day, and it should be periodical, not just binge drinking. A lot of people have a habit of drinking water in huge quantities in early morning, and that is not right. They should space it out, and it is preferable to have excess water just before going to bed. Though we know that we have a patients who other main component is we treat nocturia and we advise patients for pre-restriction. But in this situation, in stone disease patient, it is good to advise to have a small drink of water before going to bed. How do we know whether the fluid intake is adequate or not? By looking at the urine volumes to ensure that it is about 2 liters per day or about 30 milliliters per kg per day. And good to ask patients to monitor the urine color, which tells them that whether their intake is adequate or not. So if they're passing urine multiple when the various times, to look at the urine color, and to alter the fluid intake accordingly. There is the concept, the question which comes is whether to use a bottled water or a tap water. It is better to advise our patients to drink what is available. The mineral water bottles have been shown to have different mineral contents by different companies. Recent European study has shown that the bottled water marketed across Europe has different components. And in case if we are advising our patients to drink bottled water, it is better to know the mineral compositions and to guide them appropriately. Fruits, fibers, and vegetarian protein are important sources of water and electrolytes like inhibitors like magnesium, potassium, and alkali. The high phytate is helps to form insoluble complexes with calcium, favoring oxalate absorption in the GI tract. And fiber is moreover it's prebiotic, and it also helps in bacterial oxalate degradation in intestinal tract. Reducing animal protein reduces the load on renal hyperfiltration and also reduces the uric acid and reduces hypercalciuria, oxaluria, and acidosis. The other dietary modifications are mainly reducing saturated fat and increasing vegetable mono and polyunsaturated fatty acids. Reducing salt is extremely important. Shown that for 100 millimoles of sodium chloride, there is increase in urinary calcium of 1 millimoles in normal population to 2 millimoles per liter in hereditary calcium stone formers. So reduction in sodium salt reduces idiopathic hypercalciuria by 30%. So it is preferable to reduce added salt. And mainly this salt comes from the preserved food, so it is advisable for patients to restrict on preserved foods. Good glycemic control is important, and the insulin resistance is shown to lower urinary citrate and affects calcium phosphate handling and increases calcium stone and thus increases insulin resistance. Impaired glutamine system produces decreased sodium potassium transport, causes defects in uric acid acidification and increase in uric acid stones. So if you look at patient, we can classify them as calcareous or non-calcareous stones. The calcareous stones are the ones which have various metabolic factors. If they have hypercalciuria, we address them by giving thiazide diuretics. If there is hypocitraturia, we give them alkalizing agents. If there is hypomagnesemia, we give magnesium supplements. Whereas when it comes to non-calcareous stones, it is basically altering the pH and increasing the citrate concentration. The Canadian Urological Guidelines uses this index case formation, and I used it for my presentation. The case one is the calcium oxalate or mixed calcium oxalate and phosphate stones, wherein again based upon the 24-hour metabolic abnormality, the diet and the drug therapy is advised. If there is hypercalciuria, sodium restriction and thiazide diuretic. If hyperoxaluria, restricting the oxalate intake and adding vitamin B6. If hyperuricosuria, reducing the animal protein intake and purine intake and adding allopurinol. If there is hypocitraturia, to add potassium citrate. But when it comes to pure calcium phosphate stones is where the serum workup is very important, and looking at serum electrolytes, serum calcium, phosphate, and assessing intact parathermone is important. And if it is primary hypothyroidism, to get an endocrine referral. And if it is distal renal tubular acidosis, the treatment is by potassium citrate. Uric acid stones, basically the treatment is altering the urine pH, and this is one stone which responds well to oral dissolution therapy. The objective is to maintain the pH around 6.5. If there is a hyperuricemia, then to add allopurinol, otherwise it is not recommended. Most important is to address the metabolic syndrome by lifestyle changes, weight loss, and good glycemic control. Cystine zones are the one which are very challenging. The quantification of cystine in urine is important. If it is less than 250 milligram per liter, then dietary modification and organization is sufficient. Here we need to trust the importance of hyperdiuresis, which is having a fluid intake of more than 3 liters per day, protein restriction to less than 0.8 milligram per kg, low salt diet, as sodium increases cystine excretion and also increases cystine solubility. The alkalization is done by potassium citrate. We don't have to use the dose which is advised in hyperuricosuriya. The dose here should be 10 to 20 milliequivalents per day is sufficient. There is a limited role of alkalization in cystine, but is one of the therapies which people use. When the urinary cystine concentration is more than 250 milligram per liter, then we need to add chelating agents. The commonly used are thiopronine, dipencylamine, and captopril. They complex with the cystine and form cysteine, which is more soluble than cystine. Thiopronine is a second generation chelating agent, and it is found to be less toxic than dipencylamine. Recently, the thiol entry-coated tablets have come in. The advantages of this is that we can use it in less frequent dosage, thus increases the compliance, and it is still in the testing process. The hyperuricosuriya, hypercalciuria, the indication for thiazide is when patient has modest to severe hypercalciuria, and thiazides work by inhibiting sodium resorption and enhances calcium resorption in the distal tubule. It indirectly enhances sodium and calcium resorption in proximal tubule via volume depletion. The side effects include hypokalemia, hypocitraturia, hyperuricemia, and hyperglycemia. So it is good to use supplemental potassium citrate along with thiazide diuretics. Other area where the quantification of the crystal is important is hyperoxaluria. First thing is we rule out is there any presence of bowel disease in form of celiac disease, Crohn's disease, or intestinal malabsorption, or history of bowel surgery. In that absence, urinary concentration, if it is oxalate concentration is less than 75 milligram per day, it is idiopathic hypercalciuria and primarily treated by diet modification and use of pyridoxine and magnesium. If the urinary oxalate concentration is more than 75 milligram per day, then we need to do further evaluation for primary hyperoxaluria. Lumasiran is a recent drug which is being tested. It is a small interfering RNA which binds to specific messenger RNA and prevents the protein enzyme from being translated. These are highly organ specific, and then they target the endogenous oxalate pathway. This has been shown to reduce oxalate concentration by 60%. And is found to be very useful in patients with primary hyperoxaluria type 1. It is available as an injection, used subcutaneously, and there is a loading dose is monthly for 3 months, and this is followed by monthly injections later on. The most common side effect is injection site reaction. Nedosiran is something in the similar group of agents, and it targets liver lactate dehydrogenase, which is the final enzyme and converts glyoxylate to oxalate. And if it is approved, nerosuron can be used for treating all three types of primary hyperoxaluria. Raloxolase is a crystalline formulation of the enzyme oxalate decarboxylase, which breaks down oxalate. It specifically breaks down oxalate in the gastrointestinal tract and is being studied in enteric hyperoxaluria. Raloxolase is taken with meals and snacks and requires multiple doses per day. Further studies are being performed to determine if raloxolase treatment translates into reduced clinical stone events. We also have oxalovac formogens in the market, which is also useful in treating patients with enteric hyperoxaluria, but the results are conflicting. The other happening area is immunotherapy, which is the buzzword in urology, uro-oncology these days. And calcium oxalate stone formation and recurrence due to renal inflammatory promoters have been looked at. And there are pro-inflammatory macrophages, which are important effectors of calcium oxalate stone formation. And anti-inflammatory macrophages have a healing property when it comes to calcium oxalate induced inflammatory damage. So this mechanism is being extrapolated to look at successful therapies in preventing calcium oxalate stone formation. So this is a good area which is happening. To leave you with a thought, what Hugh Anton said 100 years ago. The formation of stones in the urinary tract has long been a problem of the greatest interest and difficulty, both to pathologists and urologists. While modern diagnostic methods have greatly improved the treatment, yet the inability from which we still suffer, surely to prevent recurrences, makes the therapy of the disease unsatisfactory. Thank you.
Thank you, Viswaroop. That was a very comprehensive presentation on the different aspect of, I think, the metabolic evaluation. I think you nicely covered the importance of right from history taking to the serum biochemistry, urine analysis, the different forms of metabolic evaluation, the simplified, abbreviated, and the comprehensive or extensive evaluation. I think very nicely about the stone analysis. The diet management and the drug management in the different condition also has been nicely put to the attention of everybody. I think the newer drugs like you have for primary axillary and the different types of hyperglyuria, that also you have covered. The role of the evolving role of the immunotherapy also, I think you made a reference to that. So I think the whatever a resident needs to know about the evaluation of a stone former as a primary or a recurrent stone former has been nicely covered. And I'll request residents, if they have any question, they can put on the chat box, and that will be taken now. And let me see, one question has come. This is from Gopal. How many days, months you use thiazide diuretic in calcium oxalate stone? So this is the question from Gopal.
You have to continue medical treatment is an onward process, and we need to check the response by 24-hour urine analysis, which is done at 8 weeks or a 3-month period. And based upon the response, we can reduce the dosage or look at other alternatives.
We don't do evaluation repeatedly when the patient is on thiazide diuretic. Am I right?
Yeah. No, at least for the 24-hour analysis, because the objective is to address hypercalciuria. And we need to know whether that is happening. And we need to have a checklist. So better to repeat the 24-hour analysis at least at 3 months period and take it from there.
Any other question or doubt from the resident? Okay, this is a question from Dr. Prabhakar Srinivasan from Salem. He has put a question to you regarding recurrent stone formation in CKD patient. Is it safe to use thiazide or potassium citrate?
No, here both, because patient with CKD, there is potassium citrate needs to be used in moderation. We can switch over to sodium preparations at this point of time, and also better to take a nephrology opinion at this point of time before we start giving medical treatment.
I think there are only few companies who make citrate solution without potassium, but I do remember they don't have the potassium component in that citrate solution. I'm forgetting the name of
the citra soda is available, but that so sodium bicarbonate can be looked at in these patients. It is less costly and yeah.
Yeah. Let me go to next question now. This is a very lengthy question, and this is from Dr. Sanjeev Mehta. I think this is his comment on that how you can do urine metabolic profile with a software, and you can know about the saturation and supersaturation of different components of the stone. Yeah.
This is a lithorisk.
Yeah.
Lithorisk.com, which is the one which is coming up with this. They had initially, it was supposed to be with they had problems with certain software, but now they made it as an open software and it can be used by anyone. We can put in the data and that will calculate the supersaturation and then gives us the risk component. But we should have done a 24-hour workup on that.
Yeah. Let us assume we have removed the stone and we have done the stone analysis, and I know the component of the stone, the primary component, the other component of the stone. Can we just manage the patient based on the stone analysis, or we need to do the metabolic evaluation of all the patients, especially the recurrent stone problem?
This is an excellent question. We know that we don't have to do metabolic evaluation in all. And when we know it is a calcium stone, especially if it is a calcium oxalate dihydrate or calcium oxalate monohydrate, as we fragment the stone, we can assess to reasonable extent. And as a first step, we can always advise patient to have a dietary advice, and then in case if he has the follow-up imaging, if he shows any formation of new stones, at that point of time we can address by doing metabolic evaluation. Or if patient requests that I would like to know and I would like to have preventive strategies, then I would like to do metabolic test. Otherwise, I will tell the patient that the fluid, diet, and lifestyle changes. These are the three things I advise. Only if you have to start any medicine other than potassium citrate, then I would like to do a metabolic workup.
Yeah. Now, I think there's another question from Gopal. He wanted to know that if the metabolic evaluation is normal, and then what to do, how to counsel the patient.
This is another challenging situation we face. When somebody asks us a question, why am I forming the stone? And if we do this workup, and it may come out normal. And there is a patient who requires repeat testing in case if a clinical suspicion is on a higher side. And also to know what kind of whether he was on a normal diet or what was the life, what is the physical activity he was doing at that point of time, whether he was on, and this is actually the challenging aspect of 24-hour urine analysis, which I addressed in my talk. Doesn't mean that 24-hour analysis will come out of normal. And 24-hour urine analysis is not good for non-calcareous stones. It is better that we know it is a uric acid stone. Treat them as uric acid stones and with whatever treatment which you are following. It is very important if you are treating a calcium oxalate, calcium stones, because it could be oxalate or phosphate, and then the treatment approaches for them differs. Non-calcareous stones, we have to identify whether it is uric acid, whether it is cysteine, and then the algorithm can be followed. With calcium oxalate, it is a different issue, and that's where all the research is happening.
And Dr. Bobby, we have one more question that he's asking that with the current modalities of the TFL and the holmium, when the stone is completely dusted very nicely, how do you get a good material? Shall we keep some part of the stone and chip it, or at the end we keep some part for stone analysis, or what we should be doing, or can the dust also be submitted for the analysis?
Yeah, to answer the first part, the dust can be submitted. Especially this has been done in patients who had shockwave lithotripsy, and the stones which are collected from that were analyzed. But with especially with the lasers, the dusting, it is extremely difficult. And what everyone is looking at is to, if you are giving a component, we can get one analysis, but the stone can have a mixed component. That is what we have to understand, that stone is not a pure stone. It is a mixed stone. By giving one part of it, we get a wrong assay. So that's why we need to look at stone in entirety. And that is, as a urologist, I think the 3 steps which are being addressed or suggested nowadays is: 1, look at the stone before you fragment, have a mental picture of what it is. 2, after fragmentation, while fragmenting, see whether it is single or multiple component. 3, look at the papillary architecture, especially if you are doing flexible uteroscopy. Look at the papilla, see what is the papillary architecture, and also document those things and then analyze later on and put all this information. So this is where we are moving now, and probably this will avoid the complex metabolic evaluation which we are doing, and maybe we'll be doing those in specific situations.
Bobby, one more question has come. This is from Rutav Chaudhary. Supposing you have got a calcium oxalate stone and metabolic evaluation has showed hypocyturia, how should I proceed?
Yes, by supplementing citrate alone, because there is nothing else which is there. The address only citrate, the supplements citrate, and advise on the diet and fluid intake.
I don't have any question left which is unanswered in the chat box. I think, yeah, one more question has come. This is a question from Gopal. Which medicine you will use for uric acid stone? A potted MB6, citralca, or sodavaica?
You can use either sodium bicarbonate or potassium citrate. You don't use sodium containing alkalizing agents in patients with cystine stones. Where if there is a uric acid stone or an oxalate stone, you can use either sodium bicarbonate or potassium citrate. As far as the combinations of citrate with magnesium and pyridoxine, that is should be utilized only for patients with oxalate stones, not with pure uric acid stones.
Yeah. Rutav has asked another question. Any role of lime juice or lemon juice or say tomato juice in the case of hypocyturia?
So diet is the one which is least taught in medicine. And that's where we all fail when we address patients' questions. But when it comes to this tomato seeds is something which is overemphasized, and there are various aspects to it. But as far as lime juice and lemon juice, the literature is available, and it is shown that lemonade is good for citrate, but it may not alter the pH. So in case if you want to alter the pH, instead of lemonade, look for orange juice. So this is what is available in the literature.
Bobby, this lumicirin is available
Yeah,
in India?
It is available. It's available, and they have done phase 3 trials. And it is basically in children, so they have a different schedule based upon the weight. It is commercially available, and this is a one which picture which I took. It was from the drug advertisement which comes in Journal of Urology.
That eliminate
Oxlumo, yeah, Oxlumo.
Yeah. Okay. And as we are ending, I think the Prabhakar has asked one more question. As for the dietary changes, is it restriction or moderation? So if you can answer this question both for children and adults.
Restriction in some areas we have restriction, but basically you have to have moderation. Because, for example, when it comes to non-vegetarian diet, you don't ask them to stop non-vegetarian diet. You ask them to take non-vegetarian diet in moderation. Same thing when it comes to the beverages. So I think the moderation is the key. That is the key for, as a general philosophical rule, moderation is good in all activities.
I think this is the end of the questions posted in the chat box. Very excellent presentation and excellent response from the residents and the members for the questions related to our topic. This is a question from Sachi Sankala, that if any specific book you suggest for metabolic evaluation of stones?
See, I just actually put 3 references. Share. I just put the 3 recommended for literature. This is basically to provide insights on what is happening and how we should be looking at diet, because that is what we read less, and to get more, probably we need to look at literature from some other sources like nutrients. And as for the metabolic, this article, Integration and Utilization of Modern Technologies in Nephrolithiasis Research, provides a good summary of what is the metabolic evaluation role as of now. It is surprising that if you are looking for this material, there is plenty which is available, but we will not it all talks about the same stuff. There is pros and cons for each aspect of the evaluation, and I have just put one aspect because I don't want to confuse the residents when we are talking about the metabolic evaluation. I may have a different beliefs. Even if this is a question which was asked to the practicing urologists, it is shown that many of them would like to treat patients without metabolic evaluation, and some would like to do aggressive tests and then treat. So this is something which one has to learn over the time when they are managing patients, and when they are come across different questions from patients, so they evolve their own strategies. There is no doubt when it comes to hereditary stones, and then there are different definite indices on imaging, like if there is an nephrocalcinosis and the multiple stones are there, children, and those patients are different when they give a clinical pointer towards specific causes, and then we address that.
Bobby, the question asked is the role of milk and dairy products.
Milk and dairy products ought to be taken, and there should not be any restriction. And it is shown from studies from Italy that calcium intake does not produce stone formation. This is a common myth which is there. Including calcium supplements doesn't have much of a role in terms of calcium stone formation. But as for the dietary products, yes, it has to be taken, and adequate dietary products are very essential, not only for probiotic as well as also for calcium. Only when the calcium deficiency is there, then it produces bone resorption, and then also instigates calcium stone formation.
Gopal has asked another question. Will you prescribe Portrait MB6 for calcium oxalate stone? And he is interested in knowing for how long you can continue giving this solution, tablet or solution.
Yeah, you have to, is basically what we are treating. If it is idiopathic stone formation, continuing medical therapy may not be feasible for him because patient may not be compliant. But as far as the medication is concerned, it has to be taken for a long period. So minimal to 6 months.
Yeah, that was all from the chat box. I think a very excellent presentation and a comprehensive presentation on a very crucial aspect. Actually, many people will not give any importance for all this evaluation and the drug management. And but resident, they have to understand that at least one drug always come in one of the paper in the urology exam, whether it is action of thiazide or whether it is a action of any other drug, whether it comes in the form of renal tubular acidosis, where there's a simple evaluation, difference between simple and the comprehensive evaluation. So some sort of question is always covered. Sometimes you find the mention of lemisuran and all that in the recent ones in your drugs. I think with this, I'll thank Bobby yourself for a very excellent presentation. Dr. Kesh, connectivity was poor, but I'll still see if he's available. Otherwise, I'll pass on to Dr. Rajiv Sood for the closing remarks. First to Dr. Keshav, are you there, sir? Okay, he's not there. Over to you, Dr. Rajiv.
Thank you, Dr. Arun. And thank you, Dr. Viswaroop, for this extensive and very useful discussion today. And I think the residents and consultants all are benefited. One thing is clear: once a stone former, always is a stone former, and the chances of recurrence are always like a sword of Damocles. So this is very important topic for a urologist, and justice has been done today for this teaching. And just a minute. Okay. So thank you very much, everybody. And with this, I'll say good night to one and all. I am in a cab, so there is some disturbance going on. Thank you very much.
Thank you.
Thank you, sir. Thank you, Bobby. Thank you, Dr. Keshav. And good night, everybody. Stay safe, stay well. Thanks all.
Good night.
नहीं ये मोड़ क्यों दिया?